Hello. So I will talk in this section about anesthesia for fetal surgery. Now, a lot of, let's say, development in the prenatal diagnosis has led to early diagnosis of many fetal congenital anomalies, and timely intervention would definitely increase the outcome in the fetus and also would decrease the morbidity and mortality in these patients. Organ dysfunctions can be prevented if we can timely intervene these anomalies in the uterus itself. So intrauterine intervention has definitely come big way due to these early prenatal diagnostic techniques. In this section, I would talk about how we get the fetal surgery done. Now, fetal surgery basically is divided into different types depending upon the gestational age of the fetus. Now, most of the prenatal diagnosis of the fetal congenital anomalies are done at 16 to 18 weeks, right, of the gestation, and early intervention, the earliest intervention can be done by 18 to 24 weeks. And the first category of fetal surgery are those earliest intervention, which is minimally invasive fetal surgery. So minimally invasive interventions. These interventions I'll talk about, they are mostly needle based or fetoscopic procedures, right? So fetoscopic procedures and needle based ultrasound guided procedures. Then the second type of fetal surgeries are done in mid-gestational age between 24 to 28 weeks, and they are open fetal surgeries. And most common procedures which are done in mid-gestational by open fetal surgery is the meningomyelocele repair, the fetal lung resection, large lung masses resection, sacrococcygeal teratoma resection, debulking, etc. And the last, that is done at 35 to 38 weeks, the exit procedure, that is ex utero intrapartum procedure. Now, these treatments are mostly done for life-threatening anomalies of the fetus, in which it is known that fetus would not survive after birth. So, these procedures are done when the fetus is still in the let's say uterus, and oxygenation etc. is being maintained by the maternal fetal circulation. And after completion of these procedure, the delivery of the fetus is done, right? So these comes under exit procedure, and they are done near term. Okay, and what are the procedures which are commonly done? Like CHOWS, that is congenital high airway obstruction syndromes, in which we know the fetus would not survive. So before again dividing them, I would talk about little bit about the historical perspective of the fetal surgery. Now, first fetal surgery was done by Sir William Lilly. He did it for hydrop fetalis, a case of hydrop fetalis, in which he did a intraperitoneal blood transfusion, right? It was a minimally invasive procedure, and that was the first fetal surgery which was done. So, first fetal surgery was done by Sir William Lilly, right? He did a intraperitoneal blood transfusion. Intraperitoneal blood transfusion in hydrops fetalis, right? Hydrops fetalis. Now, after this procedure, this was a minimally invasive procedure. A lot of procedures were done between 1980 to 81. So, a lot of different type of procedures were tried, but still the fetal surgery has not arrived yet. Now, fetal surgery definitely arrived after a landmark study which was done in 2011. That was the MOMS study, management of meningomyelocele. So, a landmark study, that is management of meningomyelocele, meningomyelocele study. In this, what they did, that they compared the prenatal and postnatal repair of meningomyelocele and saw the outcome, and found that prenatal repair of meningomyelocele definitely had a better neurological outcome and better outcome in the fetus. So this was a kind of landmark study which was published in New England Journal, and with this study, lot of different kind of fetal surgery came into existence, Okay, so as I told you, the fetal surgery is divided according to the intervention done at what gestational age of the fetus. So types divided according to the gestational age of fetus. Gestational age of fetus. So first type, I told you, minimally invasive surgery. Minimally invasive surgery. So these have their own benefit, but all the procedures cannot be done by this. Minimally invasive procedures. Okay. So as I told, this is done by 18 to 20 weeks of gestation. Then we have open fetal surgery. Open fetal surgery. Okay. So open fetal surgery is done in mid-gestational, mid-trimester of gestation. So open fetal surgery. Right. So open fetal surgery, as I told you, it is done between 24 to 28 weeks. Okay. So 24 to 28 weeks. And the third type is your exit procedure. That is ex utero intrapartum treatment. Exit procedure. Now, these exit procedure or exit surgery is done near term and after the surgery of the fetus, the delivery of the fetus is done in these procedure. So, all these three types have their different anesthesia requirement and have different implication in the fetus. So we need to understand these surgeries, what are different type of surgeries which comes in these categories. So I've just made a table in which I would just tell you what are the important surgeries which comes under minimally invasive, which comes under open fetal surgery, and which comes under exit procedure. So fetal intervention, which comes under minimally invasive fetal surgery. As I told you, these surgeries are mostly the ultrasound guided needle based or fetoscopic procedures. So simple things like fetal genetic sampling for genetic mapping of the fetus can be done by these procedures. So percutaneous umbilical blood sampling for fetal genetic testing, then intrauterine blood transfusion in your fetal anemia or in let's say anemia polycythemia syndrome or Rh isoimmunization or critical aortic stenosis, right? Patient with critical aortic stenosis, balloon valvuloplasty can be done, right? Then radiofrequency ablation for twin transfusion syndrome or your trap sequence or for selective IUGR procedures can be done, right? Then your cord coagulation and transaction for twin transfusion syndrome or trap sequence or selective IUGR. Then number of times the interstitial laser coagulation for sacrococcygeal teratoma, thoracoamniotic shunt placement for congenital pulmonary airway malformations, the vesicoamniotic shunt for bladder outlet obstruction. So these are minimally invasive procedures which can be done very early in the gestational period, right? And this would improve the outcome. Then we have fetoscopic procedures like laser photocoagulation, which is done for the twin to twin transfusion syndrome, right? And for anemia polycythemia syndrome. Now, fetoscopic endoluminal occlusion, a feto procedure, a very popular feto procedure done for congenital diaphragmatic hernia, in which the trachea of the patient or the fetus with congenital diaphragmatic hernia is occluded for the growth of their alveoli, growth of their lung. Then amniotic band release for amniotic band syndrome. Now, ablation of posterior urethral walls for bladder outlet obstruction. So these are minimally invasive procedures. The advantage of these procedures are that a normal vaginal delivery is possible after these procedures and even in subsequent pregnancies. In the current pregnancy, also in subsequent pregnancy. So what is the benefit? Benefit of minimally invasive procedure? That vaginal delivery is possible after procedure at term. Normally vaginal delivery can be conducted at term, right? So no need for a planned cesarean delivery in these. So if I just show you a few examples of the minimally invasive procedures. This is the feto, what I was talking about, which is done for congenital diaphragmatic hernia. That is fetal endoscopic lumen occlusion for maturation of the lung in case of congenital diaphragmatic hernia. Then this is You're done in twin to twin transfusion syndrome, that is laser coagulation of a feeder vessel. Then this is carbon dioxide insufflation done for some procedures during the minimally invasive procedures. So these are normally needle based procedure and done in early gestational age. Then let us talk about open fetal surgery. Now, open fetal surgery, the commonest one which is performed is meningomyelocele repair. Then pulmonary robe resection for congenital pulmonary airway malformations. Then life-threatening mediastinal mass resection debulking can also be done by open fetal surgery. Then sacrococcygeal tumor debulking. So these are done under open fetal surgery. Now, this is open fetal surgery. Now, I'll talk about the steps of these surgeries. After completion of the open fetal surgery, the uterus is closed in layers. So, when the pregnancy reaches the term, then definitely a planned cesarean delivery has to be done. So, in this procedure, no possibility of vaginal delivery. Always planned cesarean delivery. Planned cesarean delivery at term. At term is done. Okay, so remember this. Then we have exit procedure, which are done for life-threatening congenital anomalies of fetus. So exit procedure, that is ex utero intrapartum procedures. Now, some airway anomalies in which it is not possible for the fetus to survive after the delivery, exit procedures are performed. So cervical teratoma, lymphangioma, or CHOWS, that is congenital high airway malformations, laryngeal web or atresia, or severe micrognathia. These patients are not possible that after delivery they can breathe on their own. So exit procedures to the airway is done for them. Then some exit procedure for big tumor resection, like congenital pulmonary airway malformations, then your bronchogenic cyst or sacrococcygeal, a big sacrococcygeal teratoma, they are also done through exit procedure for resection. After completion of exit procedure, on vaginal, the fetus is delivered out. Okay, taken out. Okay. Now, what is the contraindication of getting a fetal surgery done? If fetus has some lethal or disabling genetic disease, which let's say it is not good to put mother at the risk for those fetus who are not likely to survive because of some lethal disabling genetic disease which is present in them. So for those fetus, the fetal surgery is absolutely contraindicated, because during fetal surgery, mother is also at risk. Then other structural anomalies, multiple structural anomalies in the fetus, right? Even if we do one procedure, the outcome was not very good. So for those fetus also, these procedures are not advisable because mother is at risk, and we have to see the risk-benefit ratio. Then serious medical disease in the mother, like cardiac disease or serious cardiac disease, for which the mother will not be able to tolerate the surgery, right? Again, these procedures are not done. It is contraindicated. Okay. Now, let us talk about anesthetic consideration for fetal surgery. So when we are doing a fetal surgery, getting a fetal surgery done, we have three things to take care of. Number one, mother. Mother is a bystander. Surgery is of fetus, but the outcome and everything of the fetus depends on the mother, and mother is one of the priority thing which we have to take care of. So we have to take care of mother, we have to take care of the well-being of the fetus, and we have to take care of the connection between both, that is the placenta, the uteroplacental circulation. So three things we have to take care of. So we will target all these three things one by one. So what special consideration or knowledge we need to have while doing these surgeries? So some maternal safety concerns. So when anyone getting a fetal surgery done, right, they should be very well aware of the anatomical and physiological changes of pregnancy, right? So number one, for maternal safety concern, the anatomical and physiological changes of pregnancy should be, the anesthesiologist should be well versed with for managing the patient for a better outcome. So the anatomical and physiological changes of pregnancy should be kept in mind. Pregnancy should be kept in mind for better outcome. So the chart which I am going to show you, the important physiological changes of pregnancy, this chart one should be well versed with, that in cardiovascular system, cardiac output increases, systemic vascular resistance decreases, blood volume increases. Then for respiratory system, the minute ventilation increases, the oxygen consumption increases, FRC decreases, right? Then for GI, gastrointestinal system, they become a high risk for aspiration because of the relaxation of the esophageal sphincter. Then for hematological system, the plasma volume is increased, red blood cell volume is increased, clotting factors increase, it's a hypercoagulable stage, right? So airway, there's always a high risk for the airway management in pregnant female. So airway is always considered difficult. So airway difficulty is always considered. So we need to be aware of these changes in the mother. Now, since we know that the cardiac output increases, SVR decreases, and in fetal surgery, we have to maintain the blood pressure of the patient. So cardiac output, though cardiac output increases, the SVR decreases, and because of the pregnancy progresses, because of the weight of the gravid uterus on the great vessels, the venous return would decrease, and then this would start affecting the cardiac output, and the blood pressure of the patient we won't be able to maintain. So throughout the surgery, to keeping in view the maternal safety concern, we need to maintain the left uterine displacement. So left uterine displacement should be maintained throughout the surgery, till the completion of surgery or till the delivery of fetus. Then we need to use invasive monitoring in mother for the open fetal surgery and for the exit procedure. So invasive monitoring and additional IV access for exit procedure, especially even for open fetal surgery, sometimes it is required. Then tocolytic agent, we need to prevent the contraction of the uterus. So tocolytic agents are used during these surgeries, and some tocolytic agents like nitroglycerin, etc., which are very good tocolytic agent, but they can decrease the blood pressure of the patient. So inotropic support should be considered to maintain the perfusion. So tocolytic agents like nitroglycerin, they increase the risk of cardiovascular instability. So vasopressor should be considered in these patients. Now, during the procedure, the risk of hemorrhage is always there in the mother. Why? Because maybe the uterine atony can happen or hemorrhage can happen. So because of all these, a proper preparation should be there for premature delivery of the fetus, and for managing the maternal cardiac arrest if it happens during the surgery. So full drill and everything and preparation for that should be there before getting these surgeries done. So risk of hemorrhage in setting of uterine hypotonia. So what we need to do? We need to prepare ourselves by adequate blood products, by keeping adequate blood products, especially for open surgeries, open fetal surgeries, and for exit procedure. For minimally invasive, it may not be required. So these are the important maternal concerns which should be kept in mind. That is, the physiological and the anatomical changes of pregnancy should be kept in mind. Patient should be maintained in the left uterine displacement of 15 degree throughout the procedure till the delivery or to the completion of the procedure. Then your invasive monitoring should be considered in exit procedure, and additional IV lines should always be there. Then tocolytic agents when we are using, and if the tocolytic agent causes a vasodilatation, then to maintain the blood pressure, vasopressor should be considered, and definitely blood products should be there in adequate amount in case of managing any maternal hemorrhage in case of uterine atonia. Okay. Now, what are the fetal concerns? For fetal concerns, we need to know about few very important things. We need to know about the cardiovascular physiology of the fetus, which is definitely different from the newborn, infant, child or adult. So, we need to know about the cardiovascular physiology. So, cardiovascular physiology is what we will discuss, the salient features which we need to know for managing these patients. Then we need to know how to regulate the temperature in fetus, because they are very prone to hypothermia, and mother is acting as the way of preserving their heat loss. So once they are open in these surgeries, the risk of hypothermia is very high. So temperature regulation, how temperature regulation can be done. Then when should be the blood replacement followed in them? So blood replacement, then perception of pain, whether the fetus perceives pain or not, we need to know about it. Then only we can give the medications which are necessary for the patient. So perception, we need to know about the perception of pain in fetus, when the fetus starts feeling the pain. So let us first talk about the cardiovascular physiology, how it is different. So fetal cardiovascular or cardiorespiratory physiology is different from any other individual, infant, child or adult. First, remember, the fetal circulation is a parallel circulation with total intravascular blood volume 100 to 160 ml per kg. Okay, it's a parallel circulation with a volume of 100 to 160 ml per kg. And fetal cardiac output is reported as the sum of both left and right side cardiac output. So it's sum of both left and right side cardiac output. Combined cardiac output is what is reported for the fetus. Fetal myocardium is less compliant and less mature. So contractility is not very good. So again, in fetus, the perfusion is dependent upon the heart rate. So fetal heart rate is important determinant of cardiac output. We need to keep in mind. So that's why to maintain the fetal heart rate, mostly during these anesthesia for these surgeries, we give the patient atropine, right? We give the patient atropine. Okay. So atropine is kind of always given along with other anesthetic agents to maintain the cardiac output in the fetus. Okay. Then umbilical vein contains highest oxygen level in fetal circulation. Normal PaO2 is 30 mm of Hg of umbilical vein. But to compensate for this low PaO2, the fetal hemoglobin has high affinity for oxygen, right? And Hb is also very high, 18 gram per deciliter. And Hb oxygen is, fetal hemoglobin has high affinity for oxygen. Now, fetus totally depend upon the uteroplacental blood flow and patent umbilical vessels for respiration and elimination of carbon dioxide. Now, this is a very important point which we need to keep in mind. And when we keep this point in mind, we need to know that we have to maintain the uteroplacental flow, right, very properly. Then only when we maintain the uteroplacental blood flow, right, the respiration, the oxygen will be delivered to the fetus and CO2 will be removed. That is the only way for oxygenation and the removal of carbon dioxide in fetus. Okay. Now let's talk about the temperature regulation. Now fetal temperature is closely linked with maternal temperature variation. So throughout the procedures, Maternal core temperature has to be maintained by using warm fluids in the patient, in mother by maintaining her core temperature by using warm blankets, etc. The fetal maternal circulation gradient is temperature gradient is 0.5 degree Celsius. This is the gradient or variation. Mother acts as a heat clamp, prevents the loss of heat. So when the fetus